Anthony Gonzalez here with Miami Community Health. We're here again today for another important health topic to talk to you today about. We're going to be talking about blood conditions. We're going to be talking with one of our hematologists from Baptist Health South Florida, from the Miami Cancer Institute. We have Dr. Srikanth Nagalla with us today. Welcome, Sri.
Thank you very much for having me on your show.
So today we're going to be talking about benign hematological conditions. We're going to talk about what a benign hematologist is. Now, it's a little confusing. Why would a benign hematologist work at the Miami Cancer Institute? And you know, obviously, hematological conditions are conditions of the blood. And we're going to be talking today about anemia and blood clots. Those are very broad topics. Everybody has somebody with anemia, and what are the causes of anemia? Blood clots, you must have had a family member who makes people at risk for blood clots. So those are two big topics. But before we get into our medical topics, let's understand a little bit more about Dr. Nagalla, and I want him to tell us a little bit about himself. So tell us a little bit about yourself, Sri.
Thank you. So I am the chief of benign hematology. So what is benign hematology? So if you take hematology as a whole, you have these cancerous blood disorders, which is malignant hematology, and then you have the non-malignant hematology, and some people call it benign hematology, and actually the latest term for that is classical hematology. So people are calling it classical hematology. But what it means is we deal with everything that's not a cancerous condition of the blood. So that's what a benign hematologist deals with. That could be anemias, low platelets, high platelets, clotting conditions, bleeding conditions. So all those things come under this non-malignant hematology or benign hematology.
Perfect. All right. And you're there at the Cancer Institute and obviously part of a big hematological oncology team. And so you guys are very specialized there in what you do. Is that right?
That is correct. Because a lot of people come in with blood conditions, and when we don't have a diagnosis, it's going to be a benign hematologist who sees you, because for all that you know, you might just have this non-malignant hematological condition or a benign hematological condition. But if it does turn out that you need the attention of my colleagues who are the malignant hematologists or dealing with it, then we do refer you there. But a lot of times it turns out to be a very simple problem, and we take care of that.
All right. So let's go over the first topic. The first topic is anemia. And anemia is a low blood count and a low red cell count.
Yeah.
So let's talk about anemia. You know, explain in a better fashion than me. Remember, I'm a surgeon. I don't know a lot about this stuff. And my patients never have anemia. No, that's not true. But what is anemia, and what are the types of anemia that exist?
So when you get a blood counts, when you get your blood counts, there are different numbers you're looking at. You're looking at the white blood cells, you're looking at platelets, and then you're looking at the hemoglobin or the red blood cells. So the white blood cells are important for infection, to prevent you from having infections. The platelets are important for preventing bleeding complications, to make sure that you're able to form a clot. And the red cells carry oxygen, and they're important for giving your muscles or all the other organs the oxygen that's needed for them to function normally. When the hemoglobin goes down, which could be the red cells are going down, the hemoglobin goes down, and there's one more number called the hematocrit, they're all representing the same thing, then that is called as anemia. So, which means your oxygen carrying capacity is less, so you can have a lot of symptoms and signs from that.
So I understood as a surgeon, there are only two ways you can become anemic. Either you're losing blood or you're not making blood. Is it as simple as that?
Perfect. That's as good as that. So you're either not producing it, or you're actually destroying it. But there could be conditions where both are happening to some extent. But yes, those are the two broad categories we're going to be looking at.
Okay, so in your practice and people that you see, what are the most common causes of anemia?
So nutritional deficiencies are common. And when I say nutritional deficiencies, that's iron deficiency, because whether it's females or whether it is males who are greater than 50 years of age or 60 years of age, you could have iron deficiency as one of the causes for anemia. And that's the most common reason why we see patients. But then there could be vitamin B12 deficiency, there could be folic acid deficiency, and then you could have conditions where you're not making enough erythropoietin, which is important for making the red cells, the hemoglobin. That comes from the kidney. So if you have kidney disease, that's a problem. And then you could have inflammatory conditions like rheumatoid arthritis, lupus, and this inflammation causes chemicals to prevent your bone marrow from making cells. So that's one condition. Again, anemia due to blood loss is another condition. And then there are some bone marrow conditions where your bone marrow is not healthy enough and it's not making red cells. So these are all the various conditions.
And so, how does somebody know if they're anemic?
Yeah.
Of course, you should go to the doctor.
Yeah.
And I even tell 30, 40-year-old patients, that they see me for hernias or
Yeah.
bariatric surgery. When was the last time you saw the doctor? It's been years. You need to go to the doctor. So, of course, a blood test will tell you.
Sure.
But how would you suspect at home that you may be anemic?
That's a very good question. So let's say the normal hemoglobin is around 13 for a male or around 12 for a female. You're not going to notice much of a difference when you're at 11 or 11.5. But as the hemoglobin continues to go down, then you start feeling the effects of that, which could be you're feeling tired, you're feeling fatigued, you're no longer able to keep up with your kids running around in circles. You kind of have palpitations, which is you can feel your heart beat fast, or you could have chest pain, especially when you're exerting yourself or you're exercising. And then you can, if you're an avid tennis player, you're no longer able to do what you used to do. So I think these are all some of the things, and headaches are common, or sometimes ringing sensation in the ear. So these are all some of the signs or symptoms that you're going to be experiencing when the hemoglobin continues to drop and you become more and more anemic. The subtle differences usually are picked up just with a blood count when you go to your primary care physician or some other physician. But as you go lower than 10 or lower than 9, then you start seeing some of the signs and symptoms that I just mentioned.
Yeah, and I've seen people that they'll be, they'll show up at 6 or at 5 hemoglobin, and they just felt sluggish and they were surprised. So your body compensates very well. Is that right?
Absolutely. So you have this miraculous body that is able to adapt to lower hemoglobins, especially when the anemia is happening over a period of time. Let's say you are at 13 hemoglobin and suddenly you had a bleeding episode and you fell to 7, your body is not able to compensate because you will feel the effects right away. But if this is happening over months to years, then if you're in a very good shape, you're able to adapt to it. In fact, you start forgetting what normal feels like because this becomes the new normal. And then when somebody corrects this for you, you're like, oh, this is how normal felt like. So yes, you're absolutely right.
Wow. Okay, so if you're feeling run down and you're feeling weak and you're feeling, maybe some chest pain or the ringing in the ears, you talked about the headaches, you should go to your primary physician, right,
Absolutely.
first and get a blood count.
Yeah.
Right? And then what are you going to see something in the blood count that's going to be able to tell you what is the cause of that anemia?
Yes, just with the blood counts, you could say, because you can look at the size of the red blood cells. If the size of the red blood cells are small, you can suspect iron deficiency anemia. If they're large, it could be vitamin B12 deficiency or folic acid deficiency. And if the size is normal, you can suspect some of the other anemias I was talking about. And then there is something called as a reticulocyte count, which is the young red blood cell index, because when you are having anemia, the bone marrow has to put out a lot of red cells. So these young red blood cells called reticulocytes have to come out. Now, if that is lacking, then you can say maybe the production is at fault. That's the reason I'm not able to see these young red blood cells. Or if they're too high, then you can say maybe I'm destroying my red cells or losing it as bleeding, so the bone marrow is compensating. So yes, just by looking at the blood counts, you can say, you can be pointed towards one anemia versus other, but we do need further labs to confirm that.
So then the question is, who should be seeing you? Does everybody with anemia need to go see you or one of your colleagues, the hematologist, or only certain types of patients with anemia?
So a lot of things like iron deficiency can be taken care by the primary care physician by giving oral iron supplementation. But again, oral iron supplementation can cause side effects, like you get more constipated. If you're already having GI issues, you get more constipated. And then the best treatment would be to give you IV iron. So again, a lot of times primary care physicians and others in the community, your family physician is not equipped to do that. And that's the reason people come to us. So it might be a good thing, to start with your primary care physician. And if the primary care physician feels that there is a need for further evaluation, then definitely seeing the hematologist is the next step.
So we've learned that, anemia, of course, iron deficiency or nutrient deficiency or B12 deficiency can lead to anemia. So you replenish them with what they're missing. They're their nutrients they're missing. What are some of the other causes of anemia, and what other treatments are there for those? You talked about inflammatory conditions as well. So what happens in those conditions?
Yeah, before we go to that, I would also like to say, what are the causes of iron deficiency? See, iron deficiency is very easy to correct. You give them IV iron or you take oral tablets, you're corrected. But it's not correcting that's important. You need to figure out why you're iron deficient. The cause for iron deficiency is usually bleeding, bleeding, bleeding. So if you're above the age of 50 or 40 or 45 or have a family history of colon cancers or other GI cancers, you have to see your gastroenterologist to make sure that there is nothing sitting in the colon or the small intestine that's causing this bleed. And then for young females, it's usually menstrual bleeding. That's the most common cause. And then sometimes people have celiac disease or celiac sprue where they're not able to absorb the iron. And one of the causes in 2022 is everybody is taking a proton pump inhibitor. That is your Nexium, Protonix, all these kind of medications. And you need stomach acid for people to absorb iron from your food. But when you're taking these drugs, these acid blocking drugs for a year or 2 or 3, then you no longer absorb iron properly and you become iron deficient. So these are very easy things that to look for, and it's good because you don't want to miss an early colon cancer or some other GI cancer that is fixable, and you don't want it to become a late stage. So that's the iron deficiency part. The other anemias, of course, if it's not iron deficiency, if it's not vitamin B12 deficiency, definitely we look for inflammatory conditions. And we rule out all the common things like hemolysis, which is you are breaking down the red cells. You don't have nutritional deficiencies. You don't have inflammation. Then we start looking at bone marrow conditions. There are bone marrow conditions which could be even malignant conditions like leukemia, lymphoma, and other things. But there are things where there is abnormal protein that's produced by cells called plasma cells. Then it turns out to be a condition called multiple myeloma. But I don't want any of you listening to this to go away and start thinking that anemia means cancer. No, not at all. So what I'm trying to say is there are a lot of common, easily fixable things for anemia. But once we rule those things out, just to be thorough, we also look at the rarer causes.
Yeah, so what I'm understanding is it's much more complicated as in just
Exactly.
you're not making it or you're losing it. You know, I think there are more aspects to it. There's testing there that I don't even know about that you're checking to see if the red cells are being broken down or broken too early, because a red cell has a certain life expectancy. And if they're dying early on, or you're not even the factory, which is your bone marrow, can't make the red cells because of something else happening. So I think the take-home message is, you know, if you're feeling run down, you're feeling, you know, headaches, you got the ringing in the ears, you've lost your stamina, find out if you have anemia with your primary physician. And if it's not so simple to fix, or, you know, we don't know the cause, see a specialist.
Absolutely.
Right? I mean, we're in Miami, we're in a big city where there's specialists, and we have the benefit of specialists like you that can look at all these aspects of the care.
Completely agree with what you said and how you summarized it. The one last takeaway point in anemia I want to say is anemia by itself is not a disease. It's a manifestation. It's of something else. So that's what we are trying to find out. So it's not that anemia is a disease, but as I said, anemia could be a symptom or sign of something larger, and we just want to make sure we are not missing that. That's it.
Wow, that's good. Very important point. So just don't, I'm anemic and just that's the way I live. There's got to be a reason for it.
Exactly.
All right. Yeah, and I've heard that too many times. Why are you, when a patient, no, I'm anemic. Why are you anemic? Well, I'm just always been anemic. Well, we have to find the reason for it. All right, so we've learned about anemia. Let's move on to clotting conditions and blood clots. And I think most of us in the lay public understand what a blood clot is. But talk to us about the clotting and what is important for us clotting, because if not, if we cut our arm, we would bleed to death if it wasn't for clotting. And clotting is very important. But there are conditions where patients clot too much, right? So let's go over that a little bit.
Absolutely. So clotting is very important, right? Because if you don't form a clot, as Dr. Gonzalez just mentioned, you are going to be having bleeding, which could be very life-threatening, and you can bleed out. That's the reason the body has to form a clot when you have a cut or you're undergoing a surgery. Now, what kind of clots are we talking about? So there are two kinds of clots. So one are called arterial clots. So there are two types of blood vessels in our body. One are the arteries, and then the other set is the veins. So the arteries take the blood from the heart to your brain, and it supplies the heart, it supplies the other organs, and the veins collect the blood from various parts of the body and return it back to the heart. Now, arterial clots are your heart attacks and strokes. Now, for them, I'm not going to talk about them today because that's where you see your cardiologist, you see your neurologist, because the treatment usually is antiplatelet therapy like aspirin, Plavix, and those are the drugs that are used generally to be treating heart attacks and strokes. We're going to talk about venous clots. So, venous clots are the clots that you go to the emergency room or to your physician with clotting in the legs. You say, oh, I'm having this swelling, I'm having pain in my legs, and it turns out to be a clot in the legs. And what happens to these clots in the legs? Because a clot in the leg per se is not dangerous, right? Okay, there's a clot there. But the clots in the legs travel and they go to the lungs. So the clots in the lungs don't form in the lungs. They're always coming from either your lower extremities, sometimes rarely from the upper extremities. So that's what makes it dangerous, because when you start having clots in the lungs, that could be dangerous because people can die due to clots in the lungs. So those are the things that we could be focusing on.
All right, so clots in the legs, we know, and I know as a surgeon, very important after surgery. Anybody who's had surgery, they know that, when you stay in the hospital with major surgery, you're getting injections of blood thinners, heparins, to prevent the blood clots in your legs, because the surgical event and the hospitalization increases your chance of blood clots. So right away, I know that's a group of patients that are predisposed to blood clots. But how about the people in our community and the people that are walking around and so forth? Who is more predisposed to having a blood clot?
Absolutely. So the thing is that most of the clots, as Dr. Gonzalez mentioned, it's happening because of hospitalizations, immobilizations, and surgeries. But that's not everything. There are people who say, hey, I didn't do anything. I was just doing my day-to-day activities, and I had this pain in my leg, and I had come in. So there are people who are predisposed to clotting just without any hospitalizations or any illnesses. And that could be because of aging, because as we age, we are more prone to form clots. It could be because there are some conditions in your blood that make your blood more thicker than the average person, that's causing you to clot. There could be conditions where you're having things like we are doing some harm to ourselves, like smoking, or people are on hormonal therapy. I mean, that's not harming yourself, but people are on hormonal therapy for various reasons. And especially when you have estrogen containing pills and others, people do have higher incidence of clotting in that instance. And we should always remember, as we age, we are also prone to have cancers. And sometimes clotting could be the first symptom or sign of cancer. So especially if somebody's over the age of 50 and they had this clot, and people say, oh, there's no reason, we need to make sure that you're up to date with your cancer screening, or you're up to date with your colonoscopies, or you're up to date with your mammograms, or you're up to date with your pap smears. So those are all things that we have to make sure that we are doing, just because cancer is another thing that could be causing blood clots.
So what if people, when they have a blood clot, I imagine they're going to get swelling in their legs, right? And most of them you should seek medical attention immediately, right? So what is done for those patients? They show up, somebody develops swelling in their legs, they end up in the ER. What is done for those patients?
So first thing, when you end up in the ER, is they have to confirm, is it a blood clot or is it something else? So just for like general education about these things, if there is a blood clot in the leg, it's very unusual that you're going to have blood clot in both the legs at the same time, because it usually happens in one leg. Unless you're hospitalized and you're really sick, it can happen in both the legs at the same time, but usually it's one leg. So if you have bilateral, meaning both legs are swelling up and they're swollen evenly, it could be other conditions like fluid buildup because of heart failure or something else. So you're mainly looking for swelling that is in one leg, pain that is in one leg compared to the other leg. So, but it's not always the rule. That it can happen, unfortunately, in some people, that you're having clots in both legs, but usually it's this swelling. Then what does the ER physician do? They get what is called as a Doppler ultrasound. So it's like an echo of the leg. So where you do that, and then you're looking for the clot. And most of the time we can easily pick it up on the ultrasound. And then they say, okay, this explains the reason why your leg is swollen. This explains the reason why you have been having pain for the past 3 days. And that's the first thing, is to confirm what it is. And then the second part of it would be treating the clot. Now, if you present with chest pain, you present with shortness of breath, then they may have to, if your kidney function is good, then they do what is called as a CT, like a pulmonary CT angiogram, looking for clots in the lungs. So that's the test you do for lung clots. And then once they confirm that, again, we move on to the management part, which is how do you treat the patient?
Right. And so my other question would be, do you have to also find out the reason for that clot?
Yeah.
Just like you just taught me in anemia that we have to find out the reason for the anemia.
Yeah.
Is that part of the investigation? Why did you have that blood clot?
Absolutely, yes. Because we want to know, I mean, it's a no-brainer if somebody got hospitalized. So let's say what were we dealing with in the past 2 years? COVID, right? So COVID, patients coming in with COVID or patients had COVID at home, you're at high risk of clotting. So yes, if you say, oh, I had COVID last week or 2 weeks ago and I was sick for a few days, then got better and I've confirmed to have COVID and I had this leg clotting, I know it's because of that. The reason it makes, that's a very important question, because if the clotting is caused by a provoking cause, meaning it's a strong provoking cause, for example, like a COVID infection or surgery, and it's a transient cause. What do I mean by transient? You're not going to go and have surgeries on a weekly basis. So you had a hip surgery, you had an abdominal surgery, you had a clot, then it's important to know that this clot was because of that, because we only treat you for 3 to 6 months and we stop. Because this is not something you want to keep taking, because blood thinners have side effects. So, but if we cannot find the cause, or let's say the cause is ongoing, sometimes people with a large body mass index, if they're very obese, that could also be and if we think these are not easily correctable right away and this is ongoing risk factors, or we, as I mentioned before, we want to look for cancer or something because we don't want to miss that, maybe we can detect it at an earlier stage. So once we think that there's no cause, it becomes tricky, because if I cannot find a cause for your clot and you had a massive clot, I don't know how to prevent it the next time. So the only way is to keep you on some blood thinner for a long duration, because I don't want the next clot to be fatal, because the next lung clot could kill you. So that's the reason why your hematologist or your primary care is very worried about you. It's not like we want to torture you with medications, but it's kind of in your own safety. So that's the reason why we want to find out, is this provoked with something or it's an unprovoked cause?
And you mentioned it already a couple times. So the treatment is blood thinners.
Yeah.
And, you know, in the hospital, we give a lot of injections.
Yeah.
There's a lot of medication. Let's talk about the blood thinners that we give and you know, the good and the bad about these blood thinners.
Absolutely. So before getting to the blood thinners, there's one more treatment that can be done, which is basically called as thrombolysis, or you're trying to break down the clot. We don't do it in everyone. It's not needed to be done in everyone. But if there are people who are coming with massive clot in the lungs or legs and they're very symptomatic and unstable, then they could benefit from this. And hospitals like Baptist have a wonderful interventional radiology team and cardiothoracic surgeons who could actually help with taking care of this clot. Now, for majority of the patients, we don't do it because any procedure has risks. So for majority of them, it's just blood thinners. There are two types of blood thinners. As was mentioned, you can either do injections. There used to be the heparin drip, but then now we have convenient injections, which you can take it in the belly twice a day or even once a day. There is a preparation. But for the past decade, we had this wonderful oral medications, which are like the injections, and they don't need monitoring. Why do I say monitoring? Because most of you know that, oh, my grandparents, my parents, they were on this drug called Coumadin and warfarin. They had to watch what they ate. They had to go and get their blood checked every week and keep it there. But these newer medications have a good safety profile and they don't need to be monitored. So either you can come into the hospital or you go to the ED, and if it's not a major clot, you might be able to be discharged home directly with the oral medications. Or you get admitted and make sure that you're not unstable, things are good. We give injections, and if no procedures are needed, we could then convert you to the oral pills and send you home. The last thing is you go to your primary care physician or hematologist directly, and it's a small clot in the leg. You may not even need an admission because these oral pills act immediately, so you can start them as an outpatient, and you could be discharged from the clinic. You're not even coming to the hospital. So the management has changed so much with the advent of all these options for the patients.
So if you have a clot that we know the predisposing cause, let's say I was injured, I was sick, I had a hospitalization, how long do I need to be on blood thinners?
Absolutely. So if it's a provoking cause, the answer is minimum of 3 months. But let's say you're still immobile or you have a massive clot, people might say up to 6 months. But it could be 3 to 6 months is what I would put it as. But there is a finite period of time. You don't have to be on it for a long, long time because it's a reversible cause. It was due to surgery, it was due to COVID, and you were hospitalized. Then it's only for 3 to 6 months.
And all those clots really get reabsorbed by the body, right?
Absolutely. So that's a great point that Dr. Gonzalez mentioned. It is not that the blood thinner is breaking down the clot. The blood thinner is just preventing further expansion of the clot and new clot formation. The body has this clot busting system that breaks down the clot by itself. And sometimes if the clot is so huge, it's not completely broken down and some of it just remains there as a chronic clot. But you don't need to worry about it because patients are like, oh, doc, the clot never went away. But it's okay. It's now part of that vessel. It's not moving anywhere after 3 to 4 weeks. So it's all right to be. But because of that, you could have symptoms of swelling when you stand up for long periods of time. It doesn't mean you're having new clotting. It just tells you that, unfortunately, the old clot has damaged the blood vessel, that you're going to have some residual symptoms due to that.
Yeah, that's what we call like the venous stasis disease.
Absolutely.
Some people will have some discoloration of their ankles or varicose veins. That's a consequence of clot.
It's called the post-thrombotic syndrome or the venous stasis symptoms and signs. Exactly.
Wow. So I think we've learned about 2 interesting topics that really apply to everybody. We've learned about anemia, and I think what I've learned today is that you have to find the cause. You know, anemia is not a disease. What is the underlying cause?
Exactly.
Am I nutrient deficient? Am I losing too much blood? Am I not making the blood? And the same thing with the blood clot.
Absolutely.
You have to understand, is there a predisposing condition or do you have a genetic predisposing condition as well? So, you know, obviously the importance is to seek expert care. And of course, in South Florida, we have experts in hematology at Miami Cancer Institute. So I want to thank Dr. Nagalla for being with us here today. Thank you for educating our public and telling us what everything is about. And once again, Dr. Anthony Gonzalez recommending and reminding you to be healthy and obviously take care of yourself and your family. And once again, Dr. Anthony Gonzalez, thank you, Sri.
Thank you very much for this opportunity.
Thank you. Thank you. And from Dr. Anthony Gonzalez from Miami Community Health, you guys have a great day. Thank you.